everyone. Welcome to today's webinar. We're just going to give it a minute to let people in. Okay. Again, welcome everyone to today's webinar. I'm Judy. I'm the Executive Director of F.E.A.S.T, and we're so happy to have you with us today. So today's webinar is on the topic of cognitive rigidity in eating disorders, how psychedelics may help. And we have two researchers here with us from UCSF. And just a few housekeeping rules before we start. So we'd like you to keep your cameras off and your audio off for the duration of the webinar. If you have questions, and we really hope you do have questions because we're here to answer them at the end, please put them in the chat box. And as soon as the presenters are finished, then we will answer all your questions, or at least as many as we have time for. So now I am so excited to introduce our speakers. This was kind of an interesting development of how this came about, because they sent us a research opportunity that they wanted us to publicize at F.E.A.S.T. And I had a lot of questions. So I reached out to Marissa and we set up a meeting, and she started talking about cognitive rigidity and psychedelics, and my interest was really piqued. So much so that I wanted them to do a webinar. And I'm so appreciative that Amanda and Marissa are both here today to do this webinar for us. I know this is a really fascinating topic, and I hope you all enjoy the webinar. So you guys can get started. Thank you.
Thank you so much for that warm welcome, Judy. I'm going to share my, let me put up my slides and share my screen. Moment of getting all the technology to align. There we go. All right. Well, thank you guys so much for having us join today. Amanda and I are both researchers at UCSF, and we're also physicians, pediatricians. Amanda is also a psychiatrist. She's wildly accomplished. And we treat patients with eating disorders of all types. And so we're going to tell you some about what we're learning in research and some of why we're doing this work. I do want to say that we're going to be discussing the investigational use of psychedelics, including psilocybin, for the treatment of anorexia and other eating disorders and mental health conditions. But it's really important to remember as we get into this discussion that these Schedule I medications like psilocybin are not to be used outside of research settings currently. We have FDA approval for the use of these medications in our clinical trial, and we don't recommend them. Outside of clinical trials, it is not legal to use them generally in the United States. And we also just want to give a shout out to a couple of our colleagues, Stephanie Natspek and Anita Chapakar, who contributed to some of the early work in these slides. So my guess is that many of the people on this call are really aware that, especially for restrictive eating disorders, but for all eating disorders in youth in particular, families are frontline in the treatment. We not infrequently tell families that we work with that anorexia is as dangerous as some forms of childhood cancer, that they really need to make sure that they're giving the medication of nutrition at home. And this is a phenomenal ask of families. I think you guys all probably are aware of this. And at one point, one of the families in our practice told one of our physicians, you keep telling me this is as dangerous as some types of cancer, but no one asks parents to give their children chemotherapy at home. And it's true. We really need to expand the toolkit for how to support families and people living with eating disorders. And this became so clear to both Amanda and I during the pandemic. As you guys know, the rates of all mental health challenges skyrocketed during the pandemic, especially for adolescents and young adults. The numbers in our eating disorder service at UCSF really quadrupled during that period. And while they've stabilized some, they've never gone back to what they used to be. We just see higher and higher rates than we did in the past. And I'm going to zoom in kind of on one day, one story that really moved me. And that was a day when I was in the hospital taking care of a young person who somewhat unusually did want her life to end. And that's not typical for our patients. And for that reason, her eating disorder was making it impossible for us to feed her, including with an NG tube. We could not use an NG tube or keep it in her body. And I felt a feeling of such total helplessness and powerlessness as a doctor. And as I was sitting with that feeling, what I immediately realized is this is what it must be like for families at home. When you don't have an NG tube to use and you are sitting with a loved one meal after meal, this must be so hard. And I can only imagine that it's even harder for someone living with an eating disorder and facing this challenge meal after meal. And around this time, some of the early studies and some of the early, really big studies in psychedelics in this wave of psychedelic research were coming out. And in particular, I had seen the early data from a very large study of a different psychedelic, MDMA, to treat post-traumatic stress disorder. And what shocked me about that study was first the rate of remission that they were seeing in that trial. In that first trial, they saw about 2/3 of patients go into remission and no longer meet DSM criteria for the illness. And then I saw some internal presentations about how sustained that remission was. And in fact, that some people who weren't fully in remission at the end of the trial were moving into the remission category over time. And that was unlike anything that I had ever seen in terms of a research trial for any mental health challenge. It was totally different, and I was incredibly moved by it. And then around the same time, there were also some early studies coming out related to alcohol use disorder. And one thing that we know about some patients with eating disorders and some patients with substance use disorders is that those illnesses can get really close into their sense of self. They can be very hard to let go of. And with that growing research body, I had to ask myself the question, could this help our patients? And I just want to say I felt totally crazy asking that question. Just as Judy was really skeptical, I felt like I was nuts, really starting to think this through. And Amanda and I got into the project early. We really dug into the science and thought so hard about it. So we're going to tell you a little more about psychedelics generally. Generally, one thing to know is that they're both very new and very old medicines. So some of the earliest reports that we have are that they may have been used more than 1,000 years ago amongst indigenous populations for a variety of mental health and healing and ceremonial purposes. But in the modern era, they have kind of had a couple of waves of research. Or in the 1940s, a biochemist by the name of Hoffman synthesized LSD, which is a psychedelic, and tried it himself. It was the 40s, science was very different, and had the experience of his altered state of consciousness. And this started some interest in these in the field. And then someone who was traveling to Mexico brought back psychedelic mushrooms. And there was this Big Life magazine article about them, and they kind of had this explosion into the popular consciousness. And psychiatrists started using them in research. And through the 50s and 60s, there was a fair amount of research that was gearing up using these medications. And then in the 1970s, the Controlled Substance Act went into place. And because there wasn't enough data to substantiate that these medications had a clinical benefit, they got rolled into the Controlled Substances Act and were declared Schedule I illegal substances at that time. In the late 1990s, we started to see a revival of psychedelic research. Much of that early research focused on distress at end of life. For example, in very ill cancer patients were some of the earliest trials. And we've seen sort of a growing wave of research since then. This is a graph of the number of publications about psychedelics worldwide. This is from a database called PubMed. And you can see the arrow is pointing to approximately 2020 when there was sort of a smoldering increase for a while. And then there's been this huge uptick as the FDA has made it more and more possible for people to do this research. So we're talking about many different medications when we talk about psychedelics. One group of them is what we call classical psychedelics, and that's what we'll mostly be focusing on today. This includes psilocybin, LSD, ayahuasca or DMT, and ibogaine. And then there are other medications that are sort of near psychedelics that work a little bit differently, but have some of the same properties. And this includes ketamine and MDMA. And there's a wide range of uses that they're being tested for. Depression is probably the most frequent illness that's been tested so far for psychedelics, especially depression with psilocybin. There have been those big post-traumatic stress disorder studies with MDMA, and then there are also some studies starting with psilocybin, substance use disorders, as I mentioned, anxiety, obsessive compulsive disorder, anorexia, and other eating disorders are now kind of starting to tick up. And when Amanda and I began this project, there was limited data available at that time. There were some case reports. There were some clinical trials that we could draw from where people were using psychedelics to study something else, but measuring eating and eating disordered behaviors that were giving us some signal. And then we really had to think through, with all of these different possible medications, what does the biology tell us? How do psychedelics work? So what we know about psychedelics is that the classical psychedelics, the ones that we're going to focus on today, mimic a chemical in the body called serotonin. Many of you may have heard of it. It comes up when you think about things like SSRIs, like Prozac and Paxil and things like that. It's a chemical that sends signals between neurons in the brain and body. And we know that there's abnormalities in serotonin in many common mental health conditions: anxiety, depression, post-traumatic stress disorder, anorexia. And classical psychedelics mimic serotonin. They look like serotonin. We'll show you a picture in a little while. And they lock right into the spot where serotonin goes. And this is actually critical for malnourished patients because when you're very profoundly malnourished, you can't make serotonin. You don't make enough of it. It's one of the reasons so many of our patients feel really down. And so it's medications like SSRIs that just keep that serotonin that's in the body where it needs to be don't work very well if you're really malnourished because you don't make enough serotonin. So psychedelics work because they skip that step. They lock right into that receptor and act like serotonin. And we were hopeful that that would be helpful for our patients. So what are the short-term effects? Well, I'm sure people have colloquially heard of the term trip or the sort of acute sensory and mental changes that happen when one is taking a psychedelic. So normally our brains are really efficient, especially an adult brain. We develop these like kind of super highways in our brain to help with pattern recognition and rapid processing. And that also limits the connections that different parts of our brain make at different times. But it does make us very efficient. In the short term, while the acute effects of a psychedelic are present, it allows for interconnectivity across the entire brain, essentially across the neocortex. So while in the first picture you have these really efficient, tight connections, mostly locally, kind of in the same color, you see in the second picture, there's connections all across the brain and neocortex. And this is really important because it allows new ideas to be made, new insights to be gained. It allows patients to think about things in really new ways and understand things in really new ways. And in particular, one of the things that we're interested in for eating disorders, but also many other mental health conditions, is a particular circuit, a particular pathway in the brain called the default mode network. This pathway is one of the places where patients really get stuck. All of us can get stuck there sometimes. The default mode network is responsible for how we think about ourselves. It's responsible for us thinking about what other people think of us. It's responsible for mental time travel, like ruminating about like, oh, I wish I hadn't said that. I wish I hadn't said that. So many of my patients might get stuck with ideas about what their body looks like, what other people might think about their body, what other people might think about their behavior. They might get stuck worrying about things that they have done or things that they will do in the future. And this is a place that we know from scans of the brain while people are taking psilocybin kind of loosens up while people are using a psychedelic. And that creates this opportunity to get out of these ruts and think about new ways of thinking. And that brings us to Amanda.
Yeah, so how do all of these ideas really tie into this idea of cognitive rigidity, which is, we think, kind of really inherent to the pathology of restrictive eating disorders and anorexia nervosa in particular? So, what is cognitive rigidity? And another way to say this, and we'll use these kind of interchangeably, is cognitive flexibility, right? So, cognitive rigidity is the opposite of cognitive flexibility. It's impaired cognitive flexibility. Being flexible in terms of thinking means it's the ability to consider alternative scenarios or solutions. So, can you imagine something different when presented with food, right? If that feels really aversive or threatening, are you able to learn a new kind of adaptive association with that food, for example, which is really a cornerstone of eating disorder treatment? And so, if you're not able to do that, if you're not able to shift your thinking and think more flexibly, that contributes to the maintenance of restricted food intake and eating disorder related behaviors, right? And so, we might see that someone with really impaired cognitive flexibility might have a really hard time in treatment, or our traditional treatments might fail these individuals. And so, this is where we think there's an intersection with psychedelic therapy. Now, is cognitive rigidity, is this the chicken or the egg, right? We really don't know. Is it if you're very cognitively inflexible, might that cause an eating disorder? Or is it something about the eating disorder itself that causes cognitive rigidity? And to be honest, it's probably a little bit of both. But there is some evidence here for both pathways. For example, for folks who have eating disorders, when they look at siblings who don't have an eating disorder, those siblings also tend to be more cognitively rigid as compared to other people, other families with no eating disorder pathology. So that's kind of a hint that there might be some inherited genetic component to cognitive rigidity. And on the flip side, we know that cognitive rigidity gets way worse in the setting of malnutrition. So for someone who's developed an eating disorder and then the brain is very starved, we know that they become more rigid and more inflexible. So maybe that cognitive rigidity is just part and parcel of malnutrition itself. And there's some good evidence to say that we can really improve cognitive flexibility with weight restoration. But in either case, and I'm sure many of you have friends or loved ones who have been in this experience, for some patients, even with really robust weight restoration, that cognitive rigidity piece just doesn't seem to improve with current therapy and current approaches. So again, this is somewhere that psychedelic therapy might be a really helpful intervention for a subset of patients with eating disorders. So again, kind of talking about our traditional treatments, right? Many of them use what we call cognitive behavioral framework. And so that's FBT and CBT and kind of the most evidence-based modalities we have. Sometimes where treatments fail our patients is that these modalities assume that folks with eating disorders can in fact think flexibly, can make new adaptive associations with food and behaviors. But if folks are really rigid, if we're not moving the needle on cognitive rigidity at all, then these folks might actually struggle to improve with traditional treatment that really doesn't directly target cognitive rigidity itself. So psychedelics are a way to shake the snow globe, like Marissa was talking about, how we get stuck in our default mode network. We're stuck in these ruts and patterns of thinking. When we're under the influence of a classical psychedelic, like psilocybin, for example, it's taking the snow that has settled for so long and just giving it a brief shake, right? That's the short-term change we see. We're able to kind of disrupt these really entrenched patterns and ways of being for a brief period of time under the effect of the drug. So going back to a little bit more of a sciencey lens of what this means again, right? So like Marissa was talking about, we have decreased serotonin in the setting of malnutrition from anorexia nervosa, which leads to this really overactive default mode network where we're really stuck with behaviors and rigid thoughts, right? And then when we introduce a psychedelic, like psilocybin, we see a quieting of that default mode network as that psilocybin binds to those serotonin receptors. We see brief increased connectivity amongst all neural networks in the brain. And again, this kind of bypasses that lack of serotonin from malnutrition itself, which makes it a really unique medication for our population. You can see on the right-hand side, we have a serotonin molecule followed beneath by that psilocybin molecule. So you don't need to know anything about chemistry to just see that, wow, like the center, those rings in the middle are really, really similar. And so psilocybin is acting in the way that we would have hoped serotonin would work for our folks with malnutrition from anorexia nervosa. So that's again the short term, right? You're under the influence of the drug. We see this brief window for where that default mode network is really quiet. We see increased connectivity amongst the entire brain. But then what happens, right? When the drug leaves the body, why do we think that this could be a treatment that continues to show improvements over time? And this is where we hope to see enhanced cognitive flexibility for our patients. So this we think is a key. There's something about that psilocybin binding to that serotonin receptor site or acting like serotonin that actually allows our brain to structurally modify itself and form new brain connections. This is amazing because we can do this as we get older, but man, it takes a whole lot of intentional effort. Psychedelics really kind of rapidly accelerate this process. So this little research picture here is different neurons under the influence of classical psychedelics. And you can see that it's growing new connections and new synapses over time. And what's cool about this is that this isn't a short-term thing. These are new connections that are going to stay with individuals potentially for the rest of their life, but certainly over the medium, we're talking weeks to months. We know from research that these connections persist. So this is a way to kind of grow new connections that allows us to have new ways of thinking and new ways of behaving that might really change the course of thinking and behaviors for someone who struggled with anorexia for a long time.
The far left picture is no psychedelic, and then the other three pictures are three different psychedelics, and you see all those little branches.
Thank you. So what does this mean for the long term? So we hope, right, we've shaken that snow globe, we've allowed for the brain to come up with new neural connections. And so our job then is to make sure that the snow kind of settles back in the snow globe in a way that's really adaptive and helpful for young people over time. So with that comes great responsibility, right? And that's where the therapy piece of this treatment becomes really, really critical is how do we help that snow to settle in a way that's beneficial for folks moving forward? This is a slide to say MDD stands for major depressive disorder, that this idea of moving the needle in cognitive rigidity or cognitive flexibility is not specific to anorexia. This is really what we call a core mechanism of this intervention in other pathologies too. So like Marissa mentioned, things like depression and post-traumatic stress disorder, OCD, anxiety. All of these studies are looking at cognitive flexibility and how psychedelics might improve that in the way that we're looking at for anorexia nervosa as well. So what does the model look like just in really broad strokes? How are we ushering folks from cognitive inflexibility to hopefully becoming more flexible with psychedelic therapy? So this is the typical structure of a clinical trial. So first we do really robust medical and psychological screening. Of course, in the context of a clinical trial, there are lots of inclusion and exclusion criterias, and we want to ensure maximal safety for participants coming into clinical trials. And so there's a whole host of screening batteries that are performed before folks move into the clinical trial phase. Then you can see we have preparatory and integration therapy. These are things that kind of wrap around the dosing day. So dosing day is when folks get that macro dose or big dose of psychedelic. But it's really important when you kind of look at the overarching kind of structure of this, there's a ton of therapy, right? Before, during the drug, and after. And that therapy is really critical to help that snow settle in a way that really benefits patients coming through these clinical trials. Most clinical trials have 1 or 2 dosing days or macro doses of a classical psychedelic. And then again, always with really good therapy before, during, and after the intervention. So to talk a little bit more about those phases that we saw. So the first phase, again, is prep for short or preparatory therapy that happens before you receive the macrodose of the psychedelic. That's really about really building trust with a therapist who's going to be with you during that dosing day. It can be a very big experience. And so you really need to trust the people that you're going through the experience with. We do a lot of psychoeducation during that time. So what to expect on dosing day, in terms of like making sure that folks are safe. Like, do we eat on that day? What does safety look like? Are we going to, will it be comforting if I'm having a hard time, if you're going to hold my hand, right? So talking about all of those things in advance. Setting expectations and intentions is really important during this time. So what does the patient want for themselves during the psychedelic experience? What are they hoping for? What kinds of changes feel like they need to be made? All of those things are ripe for preparatory therapy. Next is the dosing day, which we've alluded to. That's when folks are taking a large dose of the psychedelic medicine that causes an altered state of consciousness. Depending on the substance, typically we're looking at an experience of 6 hours or more, again, depending on the substance. And it's important to note that there are always going to be 2 therapists with participants during that time on dosing day. So they're never left alone during that experience. And then lastly, integration therapy. I love this phase because integration comes from the same Latin root as integrity, or, taking disparate parts and making them whole, bringing them together to really feel in alignment. So you're spending time identifying insights or emotions gleaned from the psychedelic experience, and how do we really integrate those into our lives to inform our goals, our values, and really how we move through the world moving forward. So the typical therapeutic approach is honestly evolving in the psychedelic landscape, but we know a few things. It's not as directive as our typical therapies like FBT or CBTE. It's really patient-driven and client-centered. So the participant really drives what they want the changes to look like, what the insights are going to be, and how they're incorporated back into their life. The therapists really, in some ways, take a hands-off approach here. Again, we don't specifically target weight, nutritional intake, and we don't really necessarily ask that our patients make goals that are specifically driven by their eating disorder. We take a hands-off approach and let participants guide what they want for themselves. Of course, where we do take a really hands-on approach continues to be monitoring for safety, and that's both medical and psychological. So that's where we're really, really quite hands-on. But this is different than our typical therapeutic approach. I will say there are clinical trials that are currently trying to wrap more evidence-based therapy, more structured therapy into psychedelic clinical trials. So again, this is a landscape that's rapidly evolving, but I would say most clinical trials right now are taking a rather non-directive approach still. You might hear about this idea of set and setting. This is really part and parcel of psychedelic therapy, but to shed a little light on this, set is really the mindset of the participant. So what does the participant bring to the psychedelic therapy experience that is actually really going to impact the trip and how they integrate this trip? So it's their lived experience. It's the impact that has on their beliefs, what their expectations are for this treatment, the kind of intentions they might set, and even the kind of flavor of mental health diagnosis that they bring to the experience. Our therapists and study teams really think about the set, the mindset the participants bring, and use that in the experience. And then what is the setting? Like, what's the environment in which the psychedelic is given? Do they have eye shades on? Are they listening to music? Is there a meditation before they take the medicine, right? All of these things really powerfully influence how the psychedelic trip is going to go. And as you can imagine, it's a really hard thing to study, but we know that it powerfully influences outcomes. And so it's something that we're trying to pay really close attention to in clinical trials.
So I want to kind of take us from that piece to thinking about one of the things that Amanda and I track really closely, which is that there are significant medical considerations when we are doing clinical trials for patients with eating disorders. as everyone on this call is really aware, eating disorders have both profound psychological and physical components. I think it's really important when we think about psychedelic-assisted therapy for eating disorders to recognize that there are some other mental health issues that psychedelics might appear to sort of cure almost instantaneously, where there's a lot of press happening related to some of the depression trials and PTSD trials. And in theory, for those illnesses, it's possible to walk into a dosing session with that illness and walk out without it. But it's really important to say that that's not possible with eating disorders because of the medical component. We're going to still eat these medications are a place to begin. And that's why that therapy is so important. And that medical recovery will still need to happen for many people with eating disorders, depending on their physical health. So that learning and change will require that work and support. So in terms of malnutrition, I'm sure that this audience is really well versed with some of the effects of malnutrition. This is just a handful of them. And I'm bringing these up because I kind of want to show you how much interplay there is between malnutrition and a classical psychedelic. So here I'm giving some examples related to psilocybin, the most commonly studied classical psychedelic. We know our patients who are malnourished may experience headaches intermittently. Headaches are actually one of the most common side effects of classical psychedelics. We probably see them in half of our patients who take psilocybin. Dizziness or unsteadiness is really common, and it can layer on orthostatic hypotension or hypoglycemia that causes dizziness for our patients who are malnourished. Low blood sugar, as I mentioned, of course, can happen with patients who are severely malnourished. And in our study and others, there's a lot of awareness of the fact that traditionally people don't eat while they're on a classical psychedelic. Your mind is pretty occupied, but we've had to make some safety protocols to make sure that our patients are taking in nutrition on these days. Classical psychedelics like psilocybin also make many people nauseous. We don't have people vomit in our trials, generally speaking, but nausea is very common and can stack with other issues like nausea and constipation that come with malnutrition. We know that malnutrition can cause both low heart rate and low blood pressure. Generally, we think that psilocybin increases these two, but we're seeing some variable impact, especially on blood pressure. So we're keeping a close eye on that in clinical trials. And then there's some concern that psilocybin might cause EKG changes, which we're also tracking very closely in our study. And of course, we know that there can be changes to the EKG for patients who are really malnourished. So I'm going to shift from here to talk about what's happening in the research right now. And as Judy really thoughtfully emphasized, I want to emphasize that this is research. We are still learning what works and what might be effective. It's a place of study and a place where we are putting in a huge number of safety constraints to make sure that we're keeping people safe. In the big picture, one question that our team gets a lot is, how do I find out about clinical trials? So I just want to say that from the get-go. There is a resource that is maintained by the US federal government, but really clinical trialists worldwide use it. The website is called clinicaltrials.gov, and it's an opportunity for researchers across the globe to register any clinical trials in people. It's a great database, and you can search it by all kinds of things. You can search it by illness like anorexia, ARFID, binge eating disorder, bulimia. And then you can also search it by treatment. So you could look for any new studies on an illness, or you could look specifically for, you could search for psychedelics, you could search for any of the particular medications and see if there are studies happening. I'm going to summarize the current studies happening related to eating disorders, which again is limited and growing. So there's only been one published trial to date on psilocybin therapy for people with anorexia nervosa, and this was a very small study. 10 patients, I would kind of consider it really a case series. 10 female patients all got one dose of psilocybin. There were no serious adverse events, which is great. And they did see some remission. So 4 out of the 10 patients really went into a sustained remission at 3 months of follow-up. 2 of the patients, at the time that they were dosed, sort of weren't quite meeting the criteria for anorexia based on this really annoying research tool that all of us use called the eating disorder examination. We need something to measure this, and I just want to own it's such an imperfect tool. But these were all people who had significant experience that their lives were disrupted by their illness on entering the trial. And 4 additional patients went into remission as a result of the study. And I'll also just point out that, again, we see this like early signal that maybe even if they're not in remission at 1 month, there's something happening for people that perhaps is related to this loosening of the cognitive rigidity, the increased cognitive flexibility that allows them to do more work in therapy and in their lives and allows more people to go into remission over time. So it's really exciting to see these data. There are other clinical trials happening. For anorexia, there are 3 studies that have been completed to date, but the results are not published yet for those 3. We are all waiting to see what the peer review publications look like. One trial is currently enrolling, and we will tell you a little bit more about that study. And one trial is listed as anticipating future enrollment. I believe that's in Sweden. And then I didn't put this on here because it's not a classical psychedelic, but Amanda's also running a trial to test the use of ketamine on patients on our inpatient unit to see if it kind of decreases distress and helps people eat inside the hospital. And then there's one ongoing trial for patients with binge eating disorder. This is happening in Florida, and there's no scientifically reviewed papers about this yet, but the drug company who's running the trial published some interim results on the first 5 out of the planned 10 patients. And those show that self-reported binging episodes were reduced by an average of 80% at 4 weeks after treatment. We really need to sort of see this go through scientific review, see what the final data looks like, but it's very interesting and certainly we're curious about it. And
Just a nod to,
go
I'm
ahead,
sorry.
please.
Yeah, just a nod to some of the other clinical trials that are specifically targeting cognitive rigidity outside of the psychedelic world. So there are folks who are looking at traditional FBT to see if they can help folks who struggle to think more flexibly in the context of that evidence-based treatment, as well as cognitive remediation therapy, specifically targeting this issue of cognitive rigidity. There are folks looking at different nutritional interventions. So are there different kind of macronutrient contents that might actually help the brain think more flexibly? Folks are using transcranial magnetic stimulation. Another word, we might call that interventional psychiatry or neuromodulation to get at this issue of cognitive flexibility. And then there are other medicines that folks are trialing to see if they can also improve cognitive rigidity in the setting of eating disorders. So these also you can all find on clinicaltrials.gov in case they're of interest, but just to kind of broaden the scope in terms of what folks are thinking about to improve cognitive rigidity in folks with eating disorders.
And I think it's really important to say that from Amanda's and my perspective, it's a time to be hopeful, that there are more things that are being studied than ever before in terms of new interventions and medications for these illnesses. And if there's nothing else you take from this talk, we really hope that you take a sense of hopefulness and optimism, given the number of new things and new interventions that are being studied. And so I'm going to briefly share a bit about the study that we're doing at UCSF, the study of psilocybin for anorexia nervosa in young adults. We really came to this study wanting to recognize that while our patient is at the center of the study, they're wrapped in all of these other systems and people that can support them. And that includes their family and loved ones, their therapist or mental health team, their medical team, their nutrition team, and then any structural factors that might make it difficult for them to access support. So we were thinking about all of those pieces as we came into this study. We're focusing on 18 to 25-year-olds, in part because that's our clinical focus in our practice, is adolescents and young adults, but it's also this critical developmental window. And we're hoping that if we can help people shift patterns early, it might make a really big difference over the course of their lives. Our study is formally integrating family support. So young people who enroll in this trial must enroll with at least one support person, and we encourage 2. Often those are parents, but they can also be adult siblings, they can be spouses, they can be other family members. Many different people are coming in with different support people, but we really want someone who will come into this process with the young adult in order for them to enroll. And then we're trying really hard to make sure that we are running a trial that really takes into account the experience of people with anorexia. So we have a young adult advisory board that's helped us build out some of the components of this trial. For example, we went to them and made a plan with them about how to discuss and offer nutrition on our dosing days to make sure that people didn't end up with really low blood sugars. And that plan has been very well received by the participants in the trial. We also have a parent advisory board, and both the young adult and the parent advisory board were key to helping us think about how to integrate family members into the trial, what tools to give them, because they actually do attend select prep and integration therapy sessions, and thinking about how to build that out in a way that was really helpful to everyone. And then we also wanted to think about these larger circles that envelop our patients, their therapists, their providers outside of the study. And before we even launched the trial, Amanda and I recruited people from across California who are physicians, psychiatrists, therapists who take care of patients with eating disorders to talk to them about what they know about psychedelics and what they would need from our team, both to refer and receive patients from these trials. And then every participant, young adults and family members, do an exit interview with me so that we can make sure that anything that we can change in the trial to make it more of a healing experience, more of an easeful experience, that we change those things. And we have made some significant adaptations to the trial based on that feedback. And I just really want to emphasize that we think of family and loved ones as sort of the container for this work, and that they are absolutely vital to helping us move the needle on cognitive flexibility, right? We have that short-term effect of the psychedelic, but it's this medium-term window, and we don't yet know how long that is in humans, months, maybe a year, we're not sure. But that's that key period where remission can still improve. And people can get more and more back to their lives. And one of our intentions in bringing in family and caregiver support is to give the young adults who exit the trial even more support in remembering what their insights were and what their goals were as they finished up the trial and move back into their lives. And so this is a paper that we wrote about this and our approach to this, and how we're starting to think about it as we work with younger age groups. So with that, I will just share that you are welcome to read more about our trial if you want to. There's a little code that you can scan if you want to learn any more about it. And with that, I will shift us into questions and stop screen sharing.
Wow.
Looks like we already have a few
First of
questions.
all, thank you so much. This was totally fascinating. I hope you all found this as fascinating as I did. I loved so much of what you said. I loved, the origin story of this research was passion to help people who are in pain. And that really spoke to my heart. So I'm so appreciative of the fact that you both clearly have a passion for the work that you do. And also, I'm so impressed by your inclusion of supports and family in this process. And the fact that you recognize the importance of this inclusion is also really significant to me. And also, clearly you're thorough. The process that you explained and also trying to gather information from others, really impressed me. And I love two things that you referenced. One was moving the needle. I think that, that is what we as parents and as an advocacy community really are striving for, is to move the needle on recovery. And in doing so, to reduce suffering and improve outcomes. And so I love that you framed it as moving the needle. And I also love that you framed it as hope. Because when I listen to a webinar like this, and I see two brilliant people with a passion for what they do, and I see the work that you're putting into it, and the fact that you are getting results, that really gives me so much optimism and hope that we can move that needle and we can achieve more recovery. So I'd like to say a huge thank you, not only for the webinar, but for the work that you do. and I'm going to go on to some questions. We have some really good questions. Some of them were answered, so I'm going to try to skip over those. But the first one is, can you use psychedelics in conjunction with other medications such as Zoloft or sertraline?
Yes. Great question. Early researchers were not letting people stay on these medications. And with more and more clinical trial experience, we're understanding which medications we think are safe. And in our trial, people are allowed to stay on SSRIs and SNRIs. We really don't want to rock the boat if those are helpful to people. And there's been other large trials. There was a big depression trial that similarly allowed people to stay on. And so we do think those are safe. There are some medications that we still need to help people titrate off of if they're going to do this study. So it's kind of a medication by medication basis. But those two big groups, SSRIs and SNRIs, in our trial are generally safe, and more trials are moving in that direction.
Great, thank you. What is the timeline? How long is the prep therapy and the post therapy? How long between the two dosing days? Can you go into a little bit more detail on that?
Absolutely.
Oh, and also, sorry, there was another part of that question.
Yeah.
How is the type of psychedelic chosen? Is it the family's choice or the clinician's choice? I'd
Mhm.
be a little scared about the family choice because,
Mhm.
as a parent, I don't think I have enough knowledge to choose, but
Yeah.
it's a really valid question of how do you choose
Yeah.
the type of psychedelic?
So it's set by clinical trial. So if you enroll in a clinical trial, they'll probably be only testing one psychedelic. Amanda and I really spent a lot of time in the weeds and the literature and the neuroscience, and we chose psilocybin because it is one of the psychedelics that has the most data about it already. So we had a lot of information about its safety profile, and it works on serotonin, unlike say MDMA, which works a little bit differently. And we really thought that targeting serotonin was the right choice for treating anorexia. But your scientists who are running your clinical trial will do their own deep dive, depending on what exactly they're treating, to think about that. And so it will be a long time unless these medications are sort of approved, that you'll be having that one-on-one decision making with the provider with you. And then I hope they're reading our clinical trials and thinking about that choice.
I
So
do
that
think
was one of the
that's the future,
yeah.
hopefully, right? That a provider can look at a specific patient. Are they cognitively inflexible, or is this more of an OCD type of, right? And be able to really provide a precision recommendation in terms of medication, but just not there yet.
Yeah, those are the future clinical trials that Amanda and I want to run too, is really thinking about being more and more precise with these medications. Um, and then in terms of the timeline, so it will vary by trial. In our trial, the entire intervention takes about 12 weeks from start to finish. You have two preps a couple of weeks apart. And then we always have our last preparatory therapy session is 1 or 2 days before your first dose. And some of the preps are done remotely, via Zoom, but that last one, you want to be like kind of in the room, seeing what the space is going to be like, being in the same physical space as the therapists. So that one's done in person. And at the same time in our trial, patients also have a medical visit to make sure that they are medically stable to proceed. Because as we all know, it changes over time how stable people are. And so for our study, if someone's not stable, we just delay things and we give them time to stabilize vital signs or labs, and then we dose a little bit later. In our trial, we're aiming for about 2 weeks, but it's not totally set, kind of in the 2 to 4 week range, depending what a participant needs. And you have a couple of integration sessions between those. And then at the end, we have 4 additional integration sessions. The first one is the day after the dose, the last dose, and then every week thereafter. So about 12 weeks total when all is said and done.
Okay, thank you. Are there potential differences in effectiveness between using multiple micro doses versus a few macro doses?
Yes. I think that right now, and Amanda, please feel free to let me know if you've seen something more recently. We don't have any really good data to support the use of microdosing in anything, and especially in eating disorders. There's been some studies around depression and other things, but it's not showing a lot of promise yet. So the studies that are showing promise are with macro doses. They're these bigger experiences over hours.
Okay, thank you. What other applications outside of cognitive rigidity could you see psychedelics benefiting? Meaning like, what other applications could they have outside of cognitive rigidity?
They're being studied for, I think, just about everything in the world. But so much of it does come down to increased cognitive flexibility because really a lot of it is about these new abilities for the brain to connect things that it couldn't before. Do you have thoughts about that, Amanda?
Yeah, no, I totally agree. Cognitive flexibility right now seems to be the
Mhm.
unifying mechanism across mental health disorders,
Yeah.
including things like chronic pain. So things that you might not think of as a mental health condition, but if people can change their relationship to their pain, might that also improve? So, um, there are some other ideas, like psychedelics do have anti-inflammatory properties. So there's a school of thought that some mental health disorders are caused by overactive inflammation in the brain. And so we are looking at other mechanisms too.
Yeah. And then there's some studies that are for not for medical purposes, I guess is how I would say. There's been some studies on sort of impacts on spirituality for religious leaders and things like that that I consider very outside of my wheelhouse, but that is out there in the world too.
So there were two questions which are not the same, but they are kind of interlaced. One of them is, might there be a role for psychedelics in weight-restored anorexia patients who continue to struggle with ongoing eating disorder thoughts? And the other one was asking about the use of psychedelics in people who have binge eating disorder or bulimia, not under eating disorders. So I definitely see kind of like the interplay between those two questions, and I was wondering if you could
Yeah.
answer them.
Yes. Well, first, just because I haven't already said it, I want to say the trial we're doing is inclusive of all body types and different ways that the DSM classifies anorexia. And yes, I think 100% yes. We have to start somewhere. And when you run these clinical trials for really new medications, there's often an imperative to make sure that you're doing kind of a risk-benefit calculation. So starting with malnourished patients who are in danger because of that is an important place to start. And I think that again, like literally, Amanda and I have this huge list. I can send it to you, Judy, of like all the trials that we want to do and how we want to work our way through them. And so I think yes, it's really important to help people. I think a lot of our patients are able to weight restore, but not really be free from the cognitive aspects of the illness. And I think that's 100% something that we want to study in the long term. I mentioned there's the one trial right now for binge eating disorder. I think this could be really helpful for binge eating disorder, for bulimia. I'm really interested in studying it for ARFID too. I think the one thing that needs to be true in these trials when people enroll is that it needs to be that they are motivated to do the intervention. We're doing a lot in our study to make sure that we're not enrolling anyone who feels compelled to enroll for any reason. Like, for whatever reason, people really have to come to this work wanting to do it. We don't want to dose anyone with psilocybin who doesn't want to be dosed. But anyone who I think wants to get better for any of it, that's not a good way to say it. Anyone who feels ready for this intervention, I think all of these indications could be great options.
So someone says their 25-year-old daughter tried psychedelics but reported no effect at all.
Mm.
So how common is it? She said, is it common? I'm going to ask, how common is
Yeah.
it for some
So
people just not to respond?
I think it's so important to say that there's two layers to that question. One is you have to remember that we are doing a trial of psilocybin assisted psychotherapy. We're not doing a trial of psilocybin. If psilocybin by itself made mental health problems go away, no one at Burning Man, sorry, that's a very US based reference, but no one at Burning Man would have any mental health problems, right? It's not the medication by itself.
Hi,
It's
Mom.
what the medication
Oh, sorry. I cleaned it for you. It's going to come out though.
It's what the medication unlocks for cognitive flexibility and the work that people can do after, right? So I don't know for that person if their kiddo had access to therapists who could guide them through that process and continue to do psychotherapy with them afterwards. So that's one piece. And then the other piece is no treatment is going to work for everybody, unfortunately. We don't expect that in our clinical trial, this treatment will work for everybody. We are just hoping that it will work for enough people.
So I have a question of my own that I'm going to throw in there. Cognitive rigidity is, present in so many people with eating disorders. So how do you decide who to accept? What's the exclusion criteria? Is there an exclusion criteria based on weight? And how do you assess what cognitive rigidity will respond to psychedelics, and also how far along the cognitive rigidity is? Meaning, how do you decide who to take in the study? And cognitive rigidity in theory, I mean, I've never met a parent whose kid didn't have some degree, no matter what eating disorder they have. So it's such a common, part of eating disorders.
Yeah, yeah. So we do have inclusion and exclusion criteria. You can read them on that little thing I put up that you can scan, or on our clinicaltrials.gov website. I will be honest, we don't publish all of them, in part because we don't want people to feel driven to shift any of their vital signs or anything like that artificially to get into the trial. But generally, what I would say is, for our trial, people have to have had at least one round of evidence-based treatment for their eating disorder before they enroll. This is not like first-line treatment by any means right now. So we want people to have tried something else that was really focused on their eating disorder. Many people who come to the trial have had experiences with FBT or CBT or DBT or residential treatment or some other higher level of care. And then we're asking our participants how motivated they feel to do it, right? Do they want to get better? We kind of have a series of questions about, like, do you want to get better? Do you want to be in the trial? Is someone asking you to be in the trial to get through some of those issues, to really figure out? I think it can both be true that our patients can feel really stuck and also feel really motivated to get unstuck. And that motivation can wax and wane over time with their illness. And so that's what we're looking for, is that window of like being ready to really try, and being willing to sort of jump into a very new experience, which is also really hard for some of our patients.
Okay. Two people asked, are there any of these trials that are being done on minors or people under the age of 18? I know that's not your focus, but I'm curious if there are trials being done on younger patients.
Yeah, it is. Nothing is happening yet. I think that there is an MDMA trial for PTSD that's in the works for adolescents on the East Coast, so not for eating disorders, but people are starting to move down in age. Just to be very transparent, we are writing grants to replicate this study down to age 16. It would be hard for me to imagine going any lower than that. And we're doing part of the article that I put up earlier goes through some of our thinking about how careful the screening process would need to be to make sure that a young person could think abstractly enough to tolerate these doses and things like that. So I think that's an area to move very slowly and carefully. But also, we know that the age of onset for anorexia in particular might be falling. We know that evidence-based treatment early really alters the course of the illness. And so we don't want patients who are really ill to have to wait forever if we can do this safely. And I think that's what we're really investigating now.
Thank you.
Because ketamine is approved for depression, you will see in the community a lot of folks using ketamine in adolescent populations. So that is a potential option that's available and legal.
That's interesting. Thank you. Unfortunately, we are out of time. I personally could have stayed here for much longer. But I really, again, thank you so much for this fascinating and incredibly informative webinar. As we close out, I just want to say that we rely on the generosity of our community to produce webinars like this and all of our programs and services. So if you have the opportunity to donate to F.E.A.S.T, we would truly appreciate it and put it to really good use. I would also like to invite everyone to attend next month's webinar, which is helping parents of athletes navigate return to sport while battling RED-S and/or eating disorders. It's going to be really, really interesting. Also a topic which so many of you are dealing with. And I want to give a quick plug for Feast of Knowledge. I forgot to create a slide, sorry. But on March 22nd, we have an annual conference. It is totally online. It has a digital library, so if you can attend live, you could watch all the sessions afterwards. It's an amazing program. You can go to the F.E.A.S.T website. You can type Feast of Knowledge in the search feature, or on our top banner, it says register for Feast of Knowledge. You can just click that link, but please take a look. And we also offer scholarships. If you can't afford the $60 registration fee, just let us know and we'll give you a scholarship. But I think it's a really important learning experience for parents, and we'd love to host you all. So again, thank you all so much for attending. Thank you so much, Marissa and Amanda, for being our very gracious presenters. And I hope to see you all again next month. Bye.
Thank you, Judy. Thank you all.